Marvin Zelen Symposium was established in 2015 to commemorate Marvin Zelen's achievement at Dana-Farber Cancer Institute. This symposium was established by generous gift from Marvin and Thelma and Frontier Science Technology and Foundation, which is a nonprofit organization founded by Marvin in 1970s. Marvin was regarded as the giant in the field of biostatistics. There is a picture of Marvin. The first picture was taken in his 20s as he's starting out as a young statistician at Census Bureau. And the middle picture, we took it in November 2013 in the symposium that we organized in his honor. Marvin was known for developing statistical methods and designs that were used in cancer studies. With his academic leadership, he chaired the Department of Biostatistics at School of Public Health, as well as at Dana-Farber. At Dana-Farber, he made significant contributions by integrating quantitative methodologies into global cancer clinical research. His contributions in cancer research was recognized by American Cancer Society, nominated by Dr. Browley, who was at the American Cancer Society at that time. Marvin received the Medal of Honor from American Cancer Society. One part of Marvin's research was developing statistical models to evaluate the early detection programs. He was interested in developing optimal screening schedules in various cancer sites, especially in breast cancer. I was fortunate enough to work with him on this topic for almost 18 years, and I was his mentee and collaborator and colleague. During this time, I certainly did witness his brilliance and enthusiasm in statistics. And but most of all, although he's an outstanding scholar, his legacy is generosity. He helped many of the junior statisticians to launch their careers, and his generosity of helping us was not just limited to our career matters. Those of us who knew Marvin will remember his qualities of that nature. Marvin was certainly an academic scholar, man of a vision, with generosity and warmth and nurturing mentorship. Driving force behind Marvin's success was his wife, Thelma Zelen. She is simply a remarkable lady. She's in her mid-90s, is going on to 96. Before the conference started, I just had a call with her. She was talking about her trip to Smoky Mountains. That's how she lives her life. She worked until 94, almost 94, and when she retired from Frontier Science. The middle picture is Thelma with her family, daughter Sandy Zelen, and Matt's brother Toby. Thelma was an also active member of Friends of Dana-Farber Cancer Institute, and she supported the Farber's mission for a long time. But most of all, she's a dear friend to us, to many of us. By knowing Marvin, we became her friends, the friendship that lasted for a long time and that we cherish very much. She turned 95 last year, had big celebration. Every single detail of the party was organized by Thelma herself. To honor Thelma and Marvin on her 95th birthday, we are setting up a award. This award is Emerging Women Leaders in Data Science. It's being set up under Institute of Mathematical Statistics. And Dr. Tianxi Kai at School of Public Health and Harvard Medical School, and Suchun Chang in our department are the major leading force for this work. Health disparities and cancer. I did get these definitions from NIH website. It's a very active area and important research topic in current days. Health disparities are differences due to various factors that we see. It could be social-cultural, behavior, environmental, and/or healthcare or health system. In cancer, we do see disparities, the differences between certain groups of people We see that in terms of cancer incidence rates and mortality rates, access to screening, and access to quality cancer care, staged diagnosis, cancer risk factors, or cancer-related health complications, survivorship, and quality of life. Overarching goal for the researchers in this field is to reduce disparities so that we do achieve cancer health equity. Marvin was interested in many topics, and being a forward-thinking visionary, he thought about contemporary research topics way ahead of time. This is very typical, Marvin. Oh yeah, I thought about this problem a long time ago. And he literally opens his drawer, the Paul is nodding, and he pulls out a paper or he published or notebook with handwritten notes. Yeah, I thought about this problem before. If he was here, he would be saying this for this topic today. He was very interested in disparity research long time ago, starting more than 25 years ago. So I actually got these slides from Biao Ip, who worked with Marvin when she was at Dana-Farber. This was a presentation that she made, second presentation, I believe, in 2007 in one of the statistical meetings. So what Marvin and Biao was interested in, are there cancer mortality differences in Black and white populations among clinical trial participants? So it's a limited pool of a patient, but he wanted to compare if there was cancer mortality differences. So he used the ECOG database. ECOG stands for Eastern Cooperative Oncology Group. And we do multi-center clinical trials covering many disease sites. And it's a very rich clinical database. So he and Biao looked at the ECOG data in this second analysis, using the cancer mortality between 1976 and 2005, input all the data and did a very complicated control matched analysis in that they controlled for sex, age, treatment they are in, and also institution where they enrolled from to balance the supportive care. And they compared the cancer mortality in overall population as well as male and female and by cancer sites. General conclusion that they made was there was a difference even among cancer clinical trial participants, matching every possible component we could match in the clinical trials data. There was about 12% a survival disadvantage for Black population in the ECOG participants. And the magnitude of difference varied by disease sites, as indicated here. So Marvin, as Marvin was interested in this topic, he would be very pleased today that we are talking about a topic that's very dear to him. And the second example I'm going to give you with Marvin's indirect involvement. Marvin and I are involved with cancer consortium group sponsored by NCI called the CISNET. It stands for Cancer Intervention and Surveillance Modeling Network. It started in 2000, and we are in our 5th round of a grant, and we are still going on with this group with more collaborators. So in 2000, when we joined this consortium, we developed breast cancer progression model. The model can be used to evaluate the role of interventions in terms of treatment or screening on cancer incidence outcomes or mortality outcomes. Over the years, our model has been refined. So we incorporated insight to disease into our breast model. We also incorporated molecular subtypes, which is very important in breast cancer treatment. In last couple of years, we incorporated race-specific parameters. Chinani, who's gonna give a nice conversation later, she was a part of this paper. So with these race-specific models, we looked into what controls the mortality difference in Black and white population in the US. And here too, we found that treatment to play an important role. So this is a paper that we published in the monograph of JNCI, along with our other CISNET collaborators covering variety of disease sites. So today, we have distinguished speakers, 6 speakers, who has a wide range of topics to cover in the area of disparity research. So our first speaker is Dr. Adamson. He is from Dell Medical School at the University of Texas. He's gonna talk to us about AI and melanoma disparities.
My name is Adamson. I'm a board-certified dermatologist from Austin, Texas. And I'm going to talk to you a little bit about AI and melanoma disparities. And if I have time, I like prepared a couple more minutes at the end of the talk, and I'm so happy I did because it speaks to some of what was just talked about today. All right, as a matter of disclosure, I was a former member of the American Academy of Dermatology's Augmented Intelligence Task Force. Anything I have to say, it's all my opinion, has no reflection on the American Academy of Dermatology. All right, so let's talk about melanoma, all right, melanoma prevention in people with darker skin types. Well, there are 2 general challenges. The first one is the incidence or the amount of cancer is a lot lower in darker skin types. And the second is that when melanoma develops, it's often later and clinical outcomes are often worse in people that have darker skin types. So how do we approach prevention? All right, and can AI help? So let's first level set and talk about the epidemiology of melanoma across races and ethnicities. So melanoma is largely a disease of people that identify as non-Hispanic white. So there's like a 30-fold difference between people that identify as Black versus those that identify as non-Hispanic white. And those others from other racial and ethnic groups kind of in the middle. And actually, if you include melanoma in situ or stage 0 melanoma, it's like a 50 to 60-fold difference. And the incidence is rising, mostly in the non-Hispanic white population. And mortality has been relatively flat, save for the past about 7-8 years since the introduction of new therapy. But as I said, if you identify as somebody that is not non-Hispanic white, it's associated with later detection. As an example here, if you're Black, you're at 2.5 times the likelihood of being diagnosed at stage 4. And unsurprisingly, non-white race is associated with lower survival. Here are survival curves. Top is those that identify as white, and the bottom curve is those that identify as African American. So can artificial intelligence help with these melanoma disparities? That's something that has gripped me for the past, I don't know, 7-8 years. And it has had a stranglehold on my specialty. After the publication of this paper in Nature, which had dermatologists fearing that their job was in peril. This basically was a study out of Stanford where they developed an algorithm to diagnose melanoma versus benign nevi. They used lesions that numbered in the hundreds of thousands. And this was their overall result, basically. And to orient you to this curve, each dot here is a dermatologist. The green cross here is the kind of the summary accuracy of those dermatologists. And because they're inside this blue kind of line here, basically this study showed that they were performed worse in terms of accuracy of being able to diagnose melanomas and other carcinomas compared to the algorithm itself. So this really was a tremendous result. You may be wondering to yourself, I still wonder this. Actually, I wonder why I'm here today in a conference that is put on by a data science department. You probably wonder, how does a board-certified dermatologist get involved in AI? I'm not a computer scientist, although I am a graduate of HST, so I have a little kind of computational chops. So I published a paper back in November 2017 where I looked at delays associated with the definitive surgical treatment of patients with melanoma. And not a surprise, what we showed is that if you have Medicaid or you're not insured, you have delays in your treatment. This got picked up by the press. I did not make this kind of scary title. I guess this is for clicks. And somebody clicked on it. And they ended up calling my clinic. I had a frantic call from someone saying, hey, we need to talk to Dr. Adamson about melanoma. At this time, I had just finished residency. I hadn't differentiated myself as someone who studied melanoma. And actually, there were numerous melanoma experts at UNC, which is where I was at the time, that were like, why are they calling me? So I decided to pick up the phone and talk to this person. And this is a gentleman here by the name of Avery. And this is his wife. And his wife passed away from melanoma that was diagnosed too late. And Avery is somebody who's into computer science and software development. And he said, a day, or I think you might have said Dr. Adamson at that point, but he said, these algorithms are biased. You're a Black dermatologist. We need to find some less biased data sets. Do you have any? And I said, Avery, I don't have any. I don't have data like that. But I could lend you my pen, and we can write something about this. And we wrote what is now one of my most cited papers, where we delved into how machine learning and healthcare disparities could manifest. I wasn't the first to bring this up. Do you all remember when Google Photos got in trouble because their image recognition software recognized Black people as gorillas? And in fact, I think actually, even if you pop open your iPhone, you actually can't look up monkeys or gorillas, but you can look up cats, dogs, everything, et cetera. And I have a sneaking suspicion it's because they have not been able to actually correct that as a problem, but that's just my opinion. And there's something called algorithmic justice and fairness and equity that has been pioneered by this woman who's a graduate of MIT with a PhD. And can you see what she has in her right hand there? It's a white mask. So in her graduate school work, she was unable to work with the facial recognition software because it actually didn't recognize her without that white mask on, okay? And there was this famous study around that time that basically showed that if you were of lighter skin, you were less likely to be misgendered by some of the largest facial recognition algorithms that they had out there. So 1% if you're a lighter skinned male versus 7% if you're a lighter skinned female, 12% if you're a darker skinned male, 35% if you were a darker skinned female. So what does that have to do with dermatology? Well, if you look at the data from which this powerful algorithm was drawn, it was drawn from a subset of lesions that had no acral melanomas, which are the predominant type in those with darker skin, and in fact, didn't have any melanomas really, so to speak, at all in the data set. So how could it possibly then recognize disease in darker skin types? I went to a conference on healthcare innovation and dermatology, and one of the experts in the world in the melanoma took me aside and he said, Ade, come on, we know melanoma is not a big deal in darker skin. You shouldn't get in the way of this potentially life-saving intervention. And I paused for a second. Also, I'm super junior. I don't want to say anything out of pocket. And I reminded them that, yeah, that might be the case, but this may just be the canary in the coal mine, i.e., if we don't worry about equity now for, say, a disorder that might not affect disproportionately folks of color, what about other disorders like inflammatory diseases, et cetera? If we don't care about equity now, why would we care about it later? And in fact, empirically, it has been shown that algorithms perform less well if they're not developed with diverse skin types in their training data. And here's a great study out of Stanford where they curated a large, really diverse data set of images of various different disorders of the skin. And they tested some of the highest performing algorithms that were out there on the market for the diagnosis of skin disease. And not a surprise, the performance of these algorithms declined in this new data set, but they declined more in darker skin. Well, here's the lighter skin, right? They actually declined way more in darker skin, basically showing that, yeah, in fact, if you take an algorithm and you show it a data set that is more diverse from a skin tone perspective, it will underperform. Okay, so that's not just theoretical, it actually does happen. And so there'll be a theme here with Google. So Google came out with this AI tool. Have you guys heard of this Google AI tool? Has anyone used it? Where you kind of put your phone over a lesion and then you can like take a photo of it and then it'll tell you what it is. You haven't seen it? Okay, good. Good. Okay, so I saw this, I was intrigued, and I went to look at how was it developed. What do you think? There's no tricks here. Look how few images in their training and validation set they used in darker skin types. In type 6, the darker skin type, like 0%. That's unbelievable. And like any good millennial, I went to Twitter and I, screamed into the abyss about it. And it got the attention of a news outlet in which I said the following. I said, this cavalier attitude that some in tech have when it comes to health is not surprising. They're rolling out things without necessarily thinking about the public health implications. And you know what that got me? A call from the chief medical officer of Google Health. And we had a chat. And she tried to encourage me to be patient and that they're working on it. I think they're still working on it. And so the lack of transparency about how some images are curated in these data sets and these algorithms that are developed has been the subject of this scoping review, basically showing that a minority of data sets actually even report this data, which is really important if you're trying to develop something for the use of everyone. And this is another systematic review that I was involved in, where they did the same. And not only did they show that there was little reporting of Fitzpatrick type, which is basically, how light or dark the skin is, but also ethnicity and even the ground truth of histopathology, right? And so there are problems with AI in dermatology and medicine. Algorithms, they're only as good as the inputs in which we train them on. And without those representative inputs, we have a potential to exacerbate current healthcare disparities. And so we need to really think about how we construct these algorithms now so that we don't perpetuate some issues in the future. And there's some potential solutions, right? We could oversample darker skin. You could have a separate but equal algorithm. Sounds horrible. I don't think that's a good thing to do. Or you could find digital solutions, right? And now in this era of generative AI, you could use some techniques in order to maybe mimic dark skin or increase through the use of synthetic data, the data sets on which algorithms learn. And in fact, I'm working with some people here at Harvard doing this, right? And Raj Monrai's group here, in which we take images from a database called the Fitzpatrick 17K, as well as the one that I described earlier from Stanford, and you use in painting, out painting, et cetera, to basically make synthetic images and then use those to train algorithms. And in fact, as you can see in the dotted lines here, they improve the accuracy of the models, right? Not dramatically necessarily, but this is one way in which to make improvements. But I want to stress to you that AI has way more than just a diversity problem when it comes to concerns. Here's another problem. So I don't know if many of you are aware, but how pathologists make the diagnosis, particularly of solid tumors, in many ways has not changed. I'm going to use melanoma as an example, right? You look at a glass slide, look at cells, how they're oriented, look at nuclei, et cetera. You got to make a determination of what is cancer and what is not cancer. Turns out, if you give the same pathologist the same slide and ask them, is this cancer or not cancer? And you compare that to a gold standard, reference standard, say, the best pathologists on the planet for the study of melanoma, at least in this instance. They only agree about 50 to 60% of the time with that reference data, of this being cancer or not cancer. And actually, if you give the same slide to the same dermatopathologist at 2 time points, 8 months apart, they can only reproduce the same diagnosis 60 or so % of the time, okay? And in this really clever experiment, where this is in like 92, they did this actually, it was published in 96. They asked basically the gods of dermatopathology that came to NIH, they each brought 5 to 6 slides and of what is it, a melanoma, not a melanoma. And they asked them, what do you think this is, a melanoma or not a melanoma? They agreed 13 on 13 slides. They couldn't actually agree on over 20 of them. And we wrote about this in New England Journal a few years ago, where I pointed out that if pathologists actually can't agree on what the gold standard is of cancer, and you're using this interpretation, right, which is not very reliable for both training, testing, and additional testing, are you really getting closer to the actual truth, right? And I'm just gonna leave that there.
And you said what? That was my question. What is the gold standard then? What is, who has cancer? How do you know? How do you do pathology?
Well, the gold standard is over time seeing who ends up getting metastasis and dying. But once you've biopsied something, you've interdicted on its natural history. And so you actually don't know what would have happened if you didn't do anything.
So for all these studies where they train, they actually have the endpoint already.
They don't. They're relying on the pathologist's determination in that moment. And this is particularly hard for early lesions, right? Often lesions that we try to harvest in the screening process, okay? And we proposed in this article, you know, we could actually power AI to its strengths. We could say, here are 3 buckets, 2 buckets. The first 2 are, everyone agrees this is cancer. Everyone agrees this is not cancer, okay? And then we're left with the discordant bucket, right? And that's the bucket where human interpretation could be used, or maybe we could treat this this group with you know, less intensive care, study it, right? This would only make the job of the pathologist harder. And so shortly after we published this article, Google, you know, it's reared its ugly head again. They had this really famous article about how they developed an algorithm that was better than radiologists at detecting cancer on mammograms. And we pointed out in the LA Times that, you know, this might increase the detection of disease that actually would not necessitate treatment. It could mean a lot of unnecessary treatment, particularly for early disease that has an uncertain potential of metastasizing and killing a patient. And again, comments were picked up by magazine, and then they interviewed Google and they interviewed me. And this is what I had to say about it. That, you know, there's this idea that finding more cancer is always better, but that's not always the case. The goal is to find cancers that actually kill people. And I think that's how AI algorithms need to be powered. But currently, especially for early detection, that is not how they are powered. They're just powered to find more. Okay? And then the journalist asked the folks at Google whether they would consider sorting out in a non-binary analysis as we advocated. And they just said, hey, our false positive rates were low. And this is deeply concerning for me as a clinical epidemiologist. False positive and overdiagnosis are completely different things. And so the people that are, you know, developing this technology, I feel like, should understand this really basic and fundamental problem. I think I have like 5 minutes or so. Okay, good. I finished in time. I created this part of the talk yesterday. And I'm gonna get a little provocative for a second. And I'm glad that we were talking about screening and disparities in cancer. And actually, this is what, it's this image here that got me thinking. So I think we all agree that Black Americans, and it's shown in data, have consistently experienced higher cancer death rates than white Americans. And there's widespread belief that screening can reduce these disparities. Would people generally agree in the room? If we just screen more or screen better, we would be able to reduce these Black-white mortality differences, quality of care as well. But just from a screening perspective, just show of hands, do you think that if we screen more or better, we would be able to decrease that disparity in cancer-related deaths?
I would say better, not more necessarily.
Okay. All right. So what I think is that the attentiveness to disparity is important, but this belief about screening may not be. And let me show you some figures to see if I can convince you. So the U.S. Preventive Services Task Force, in part, I think, has been motivated to reduce these cancer disparities. They've dropped the smoking history criteria, PAC years, partly to reduce these disparities. The colorectal cancer screening guidelines have also lowered the age. And in breast cancer, suspending shared decision-making for women in their 40s in favor of a blanket recommendation, in part, was motivated by decreasing these disparities. And even for multi-cancer early detection consortium, right, and some of these newer tests, even formed health equity groups, you know, and actually in congressional legislation, they have put in writing that they believe that MCEDs will reduce healthcare disparities, okay? But at the outset, this doesn't really even make scientific rationale, doesn't pass the sniff test. How would screening more in both groups reduce mortality disparities between groups, right? Wouldn't you want to advocate just more screening in one group, right? And in fact, screening is notable for its lack of disparity. And currently, Black women are screened at higher rates for mammography than are white women. Colorectal cancer, same. Prostate cancer, the difference is anywhere from 5 to 8%. But the mortality difference between Black and white men is double. Screening doesn't explain it, right? And Black women die at a 30% higher rate for breast cancer, and in colorectal cancer, something like 30 to 40% between Black and white. And actually, since 1990, do you all know this, that the gap between cancer mortality between Black and white Americans has declined dramatically? But in the place of this gap has been an increasing gap between poor and rich counties and mortality related to cancer. And in fact, now, if you're a Black person residing in a county that is more wealthy, you are at much lower risk of dying from cancer. And then lastly, this is my last slide. Let me get even more provocative. If we're talking about cancer as it relates to all-cause mortality, right? And the gap. This is all-cause mortality and cancer mortality by race in the United States. And actually, if you look at it as a Black-white difference, cancer mortality differences account for just about 15% of the overall mortality gap between Black and white Americans. I'm not saying that this means that health disparities related to cancer are not important, but I think that when we zoom all the way out, we also need to be aware about exactly where we need to put our dollars and attention. And with that, I'll stop my rant.
I had a question. You showed us the ROC curves for the one of the first AI algorithms where you had like but what was interesting was that when you showed the white and this one.
This one.
Yeah. Keep going to the next ones. So the difference between the ensemble dermatologists between the different skin categories was kind of like the drop in the darker skin categories for the dermatologists was like an interesting drop. So I guess that kind of goes back to your problem of if you don't have a gold standard, even if dermatologists, like an ensemble of dermatologists can't really tell you, then that's a big problem for doing any kind of algorithm.
That's true, and perhaps it also says something about our education as dermatologists,
yeah,
and our textbooks that don't have representative images as well.
So I have one related to the table with the vision, but this is something that happens a lot when we review protocols. the accrual of Blacks, then we know that high probability they pay. But it's difficult to have a quantitative approach to give a recommendation. It's difficult to say, okay, try to prove that you will make it. Have you seen any research or do you have any ideas for that specific?
Of like recruitment into.
Deciding what is the right percentage of
Got
Blacks that should be part of the study and make sure that it happens.
Yeah, so right, not zero. And it also shouldn't necessarily be like, you know, I don't know, 2020, right? It should reflect whatever population in which it is going to be deployed, right? So
What do you think is the right number here? in this
Here?
case?
I think if we're talking about skin diseases in general, then it should look like the US population or whatever population that you think is going to be deployed in, because there is no, I don't know, I mean, I don't think your skin type determines your risk of getting all different skin diseases, if that makes sense. But now if you're talking about a skin cancer algorithm, right? I would say, yeah, it's fine to have an algorithm that might have 1%, 2%, 3%, right? But this is not what this algorithm was designed for. This was designed for all skin disease, right? And so these percentages of darker skin types should be much higher, 5, 6, 10%, you know, 15%.
So since Patrick's skin type, is that who?
It's problematic.
So it's a person that decides that, there's no like instrument?
There is an instrument, and there's an instrument. So the instrument it was created here at MGH, and it was actually designed purely in order for investigators to try to figure out how sensitive someone was to the sun. And they only had 1 through 3, right? And they excluded people that did not identify as white initially in the making of this scale. And then eventually like, oh, maybe this is a little racist. So let's add a few more shades to it in like the late 80s. And it only was supposed to be a scale of your response to UV light. But because there's a relationship between that and how light or dark you are, it's kind of served as a stand-in for how light and dark you are. And there's a lot of internal turmoil in dermatology and how we measure skin tone and, you know, how many levels are enough. You can't have too many, you can't have too few. You know, should it be self-report? Should it be a colorimeter? People's, you know, trunk are different shades than say, you know, people's face or hands. It's really a mess.
Yeah. It's from what you're talking, from your talk, one of the things I get is that needs to be part of the algorithm. I mean, you said we shouldn't have it separate. I don't know what phrase you use, but we shouldn't separate it. But
right, have a separate algorithm for people of a certain darkness.
The covariance should be there, it seems. Like it might be an important predictor of have cancer or not.
Certainly, but we have not been able to actually easily, systematically use that in measurement.
You spoken to like funders like MSCE or maybe even some of the publications to, I don't know, encourage requirements on your building training sets to make sure that they're properly powered to, you know, for these differences?
So I would say that people, not only in you know, the academic community, but also I'd say in like the entrepreneur tech community have become more sensitive to this because of a lot of people's advocacy in this area, et cetera. There is no set standard, but I do think there's way more sensitivity to this than there was, say, 7, 8 years ago, for sure. So, and I'm a deputy editor of JAMA Dermatology. And when we get AI papers, that is something that we also think a lot about as well.
Oh, yeah.
How much of global development is there for these kind of things? Because I mean, one of the restrictions you're talking about is like, you know, the US population, I don't know what percentage is, 15% African-American, like.
Yeah, it's like between 12 and 14.
Yeah,
Mhm.
but you think globally, that's a very different story, right? So I guess that's what, has there been any work on more global development of these algorithms?
So I would say there's been a dearth of development in countries that have people with melanin-rich skin. It's been mostly in, US, Europe, Australia, et cetera. Some in Asia, as well. But even in Asia, there's such a rich amount of melanin concentration across populations. It's really a tough problem. Thank you.
Our next speaker is Dr. Dwork from Harvard University. She will talk to us today about individual groups, indistinguishability and loss, 15 years of algorithm fairness in 20 minutes.
Thank you very much for inviting me here. I'm really, in today's speakers, which of these does not look like the others. So what I'm doing is very different. But as I listen, I'm really thrilled to have heard what I've heard so far. And I haven't met an audience that had underlying interests that were as close to the ones that I have. So I think you'll see that there's some real commonality. So, great. When I thought about what is this field? Well, the field of algorithmic fairness actually began in the summer of 2010 at Microsoft Silicon Valley Research. And when we thought about it, well, it wasn't really clear what it was or what it would be, but we sort of knew that the question of bias in algorithms, unfairness in algorithms, particularly in the context of machine learning, was going to happen. Remember, this was 2010. And in fact, the question of bias in algorithms has exploded in the last decade or so in the machine learning and AI fields. And in addition, it has flourished in the theoretical computer science community, which is my community as well. So here's a bunch of topics that are in kind of my corner of this aspect of the world. And this is a bit about the path that we're going to be going through the talk. We're going to start with fairness. And with fairness, well, you want to actually design an algorithm and prove something about its behavior. You need to know what it is you want it to do. You need definitions. What does it mean to be fair? And when we started thinking about this, immediately we realized there were two very different flavors of definitions. So group definitions of fairness and individual definition of fairness. So in the group fairness examples, I'm going to be pretty brief on this, statistical parity. So you have an admissions committee and you want that the demographics of your admitted group should be the same as the demographics of the population as a whole. That's an example of statistical parity. Another could be balance for the positive class. So if you're not thinking about classifying yes, no, but instead you want to say score people or evaluate them, you might want that if you have two groups of individuals, A and B, for the purposes of this slide and a couple slides, let's say that they're disjoint. We'll get rid of that in a moment. You have people who are going to be positive examples and people who are negative examples. And what you want is that the average score for a positive member of A should be the same as the average score for the positive members of B. That would be an example of another example of a group fairness condition for a scoring function. And I want to pull out one criterion that is we're going to get a lot of mileage out of, which is what we call within group calibration. So calibration for a predictor or a scoring function, think about weather forecasting. Every day the weather forecaster says what the probability of rain is the next day, and then the next day either it rains or it doesn't, and you go on and so on. And you say that the forecaster is calibrated if you look at all of the days for which, say, the forecaster said 70% chance of rain, then in fact, on approximately 70% of those days, it should have rained. So that you could say is a kind of sine qua non of a good forecaster. It's not everything you want, but it's something that you want. And people have been studying this, well, at least since David started in 1982. Highlighting calibration as a fairness condition was a contribution of Kleinberg, Lehnathan, and Ragavan in 2016. So what they said is if you have a scoring function and you have two disjoint groups, A and B, you don't just want that your scoring function or your prediction is calibrated for the population as a whole, but you also want that it should be calibrated simultaneously within group A and within group B. So if you only look at the forecasts for group A, they're calibrated. You only look at the ones for group B, they should be calibrated as well. So that's a stronger, a more demanding condition. So with those examples of group fairness, what's the problem? It sounds great, right? And the problem is, well, they fail under scrutiny. So here's an example. Suppose for reasons of bias, you're an advertiser and you know you're supposed to advertise equally for your restaurant to people in group A as in group B. So, you know, if you're online and you're doing stuff, your chance of seeing the ad for the restaurant should be the same if you're a member of A or of B. Well, you can, if you're really discriminatory, what you can do is you can make sure that the advertisements go to you have a steak restaurant, the advertisements go to the vegetarians in group B who don't want to come to your restaurant anyway. And so you seem to be doing the right thing, advertising to two groups equally, but in fact, you're ensuring an all A clientele. So there are other examples of things that go wrong with group fairness notions, but one of the nails in the coffin, I think, for this view is was done independently for classification by Tulachova and for scoring functions by the KMR paper I mentioned before, is that small sets of very natural desiderata are mutually exclusive. They cannot be solved, they cannot be achieved simultaneously. And so you have natural things that you want, and you just can't get all of the things that you want from group conditions. So an alternative is to consider what we call individual fairness. So the general idea of individual fairness is that people who are similar with respect to the particular classification or scoring task that you have in mind should be treated similarly. They should be classified similarly or scored similarly. And that makes a lot of sense. And it has to be a little careful how you formalize it for a pair of individuals, X and Z. You might actually need to have randomized classifiers for them or randomized scoring functions. But if X and Z are sort of close for the goal that you have in mind, then they should experience similar distributions on outcomes. So there's a strong legal foundation for this kind of a requirement, but there's of course a problem. Where do you get this similarity measure? How do you know for individuals X and Z how close or how far they are? So that's a real problem. If you have a way of evaluating similarity, there's a lot of stuff that you can do. That's nice. But the bad thing is, you know, where does this similarity measure come from? Well, there has been quite a bit of work, especially in the last couple of years. There's been quite a bit of work at automatically learning distance metrics. And I think this is encouraging. And I also personally believe that there's no way around ultimately finding distance measures. You can ask me about that during the question and answer. But in the meantime, a drawback of the individual fairness notion is that it requires this task-specific metric, and we don't really know how to get it. Now, possibly in an effort to kind of bridge this gap, two groups of researchers independently came up with what I'm going to call the multi-X framework. So the idea is, first of all, you have a collection of groups that can be arbitrarily intersecting. And the groups have to be large enough. And that's like a technical thing that involves making sure that when you take samples for your training data, you get people from each of the different groups. But you have a bunch of arbitrarily intersecting groups, and you want some fairness condition to hold for all of these groups simultaneously. So the multi says this requirement is going to apply simultaneously to sets in your collection of sets, and we're going to fix that set and collection in advance. You can fix it any way you want. It just has to be fixed in advance. And then you have your fairness guarantee, and you want that all of these groups simultaneously will enjoy this fairness guarantee. So one example of this is multi-accuracy. The fairness condition is a kind of accuracy condition. Think about, in particular, scoring functions. So a scoring function or a predictor is assigning to each individual a number between 0 and 1, which you can think of as a probability, but in any case, it's a score. And what you want is that if you look at any single group and you look at the average score assigned to the members of that group, then that should be approximately equal to the number of individuals in the group, the fraction of individuals in the group that do experience a positive outcome. And here positive means the outcome is 1. It doesn't necessarily mean it's a happy thing. It might be developing cancer or dying, but it's a 1 rather than a 0 example. So multi-accuracy is, as we'll see in a moment, it's quite powerful. And a lot of questions come up. Which groups should you have in the collection? And who decides what these groups are? And who advocates and says, hey, my group should be here, and so on. This is all important, and it's not what we're talking about right now, but it's very important. And a nice thing about this approach is that in some sense, the more the merrier. Having more groups does not hurt your accuracy. It only helps, and it doesn't have a big impact on your sample complexity, how many data points you need in order to train. So more is pretty good. And I don't need to tell you what this thing says. This says be thoughtful about which groups you list. And to quote the very brilliant Dorothy Roberts, the legal scholar, the variable is racism, not race. We've heard a lot already today about structural racism. So you people know this, but many people that I talk to don't know this. So, all right. And, you know, one thing that it does is it improves subpopulation calibration. Dr. Adamson mentioned the gender shades example. So Kim Glavani and Zoe showed that this approach does a lot to improve the gender shades situation. And here are 2 examples that I chose from the medical literature. So it is, I thought maybe they would be of interest to you as an audience. So now I'm going to say something that is going to make no sense to you. And I can't control myself. So this is my land. There's something called a regularity lemma, the regularity lemma. And suppose you have some domain that you have functions that operate on, and you have an arbitrary function. So whatever I've drawn, this really crazy looking function. And suppose you have some collection of possibly simple functions F. The regularity lemma says that this wild function G can actually be approximated in a certain sense by a very simple function H that, as far as the functions in F are concerned, looks the same. So the functions in F can't distinguish complicated G from simple H. And if that sounds really crazy, if you've ever heard of pseudo-randomness, the whole idea of pseudo-randomness is you have something that looks random, but is actually not random. What that really says is, to restricted classes of distinguishers, they look random, but they're not really random. But if your distinguisher was smart enough, it could notice. And there are lots of applications to this in number theory, having to do with the distribution of prime numbers, information theory, complexity theory for computing, graph theory, and cryptography. And here's one of the reasons I love it. It turns out that multi-accuracy is actually equivalent to regularity. So that very natural condition that I talked to you about being accurate in expectation on each of these different groups simultaneously, turns out to be mathematically equivalent to regularity. And while regularity theorems had been proven, the multi-accuracy work that I mentioned earlier actually shows you how to construct these multi-accurate predictors. And a strengthening of multi-accuracy is called multi-calibration. So we're back to calibration. And now what we're asking for is that the predictor will be calibrated on each of these sets, arbitrarily intersecting sets. If you look at any one of them individually, the predictor will be approximately calibrated on that collection. And so it's a strengthening of multi-accuracy, and it has stronger mathematical consequences, and it leads to a lot of very powerful tools, which I will mention in a moment. But now I want to talk about the philosophy of probability. So we're interested in being able to assign a risk score to an individual. And so if we think about individual days, we're asking what's the probability that it'll rain tomorrow? But for a lot of other things, or maybe assigning probabilities to individual people. What's the probability that X will repay the loan? What's the probability that this tumor will metastasize under the following course of treatment? And so on. And the problem is that this question makes no sense. If you get into the meaning of probability, this thing, it's not at all clear what it means, and people have been talking about this for decades in the philosophy of probability. What is the probability of a non-repeatable event? I can't like send someone to college, see if they complete it in 4 years, rewind the clock, send them again, and count what fraction of times they actually do complete. So what does it mean to say they have a 80% chance of completing in 4 years? So this caused the community to think about, kind of rethink the goal of machine learning. So outcome indistinguishability, you heard me hint at it before when I said these functions can't distinguish H from G. So outcome indistinguishability is a notion that has its roots in complexity theory, and it provides an avenue of attack for this. Basically, OI frames learning not as loss minimization, which everybody who has actually run an AI algorithm or machine learning algorithm thinks in terms of loss minimization. But here, the goal is to fool a class of distinguishers. So we introduce the idea of, here's a distinguisher. You give it examples that are drawn from real life. You give it examples that are drawn from the predictive model, and none of them should be able to tell which is which. That's one way of saying you've got a good predictor. So again, for each distinguisher in our class, we can feed to this distinguisher an individual and an outcome, and they try to figure out, the distinguisher tries to figure out, was this the real life outcome from this person, i.e. like in training data, or is it just what the model would have predicted? And you can, once you kind of frame it this way, you can actually start building a hierarchy of indistinguishability notions that vary according to how much information you give to the distinguisher. So in one case, you might just give individual outcome pairs. In another case, you might give an individual the score according to the model that you've built, and then an outcome which is either drawn from real life or according to that model. And the distinguisher tries to tell which is which. And I'm only showing you the first 2 levels of the hierarchy. And it turns out that the first level is equivalent to multi-accuracy, mathematically equivalent to multi-accuracy. And the next level is equivalent to multi-calibration. And between these 2 different ways of looking at multi-calibration and outcome indistinguishability, you know, each perspective lets you do different things easily. So it doesn't matter. Since they're equivalent, you just use whichever one you want that helps you. So we get improved calibration error for subgroups. We get, for those of you who know what agnostic learning is, here you have a learning algorithm which gives agnostic guarantees simultaneously to every set in the population that you have pre-specified. You can define notions of what does it mean for ranking functions to be fair among different groups, and you can ensure fair ranking. You can build predictors that have the following property. I'm going to lie, I'm going to exaggerate, and you can ask me how I'm exaggerating later. But the idea is you train once, And if you want something that is good with respect to loss function 1, you do a special post-processing of the trained outcome to get that loss function, to get a good choice for that loss function. If instead later you decide you're interested in loss function 2, you don't have to retrain, you just do a different post-processing to do well on loss function 2, and so on. The way on which I'm lying is that you kind of have to say in advance which functions you're competing with when you say you're doing well with respect to that loss function. You can ask me about that during the questions if you like. Let's see. We get new results in complexity theory, new proofs of old results. And we also get what I want to call better worlds. So this is the last thing I'm going to mention, which is all along in this literature, so much has been accuracy as fairness. And the literature will even talk about nature. So individuals are drawn from nature, and this is the probability of success that nature awards to the individual. But of course, we know that that's nonsense, that the chance of success is contextual. So imagine you have 2 different news organizations, Nice News and Nasty News. And at Nice News, it's a supportive environment, and everybody is mentored and helped to achieve their maximum potential. And at Nasty News, it's very misogynistic. So clearly, a woman has a different chance of succeeding at Nice News and at Nasty News. And the difference isn't located inside of her, it's contextual. The environment plays a role. And of course, as you know from like the work on epigenetics and other things, who we are is contextual. So the air, the water, the housing, the education, our parents' connections, healthcare, whether we have a supportive or not community, all of these form us. And so we've got a lot of technology set up for trying to understand and predict what's going to happen in the real world, but we might be interested in knowing kind of what could happen. So we could imagine a utopia, and the real world is just some horrible distortion and crushing, soul crushing that brings, starts in utopia, and you get this transformation that takes you to real life. And there are ideal success, how you would succeed in the ideal world, utopia, and there's your chance of success in the real world. And the transformation destroys information, destroys people, but it destroys information. We can't mathematically undo it. Nonetheless, and there are no data, there's not even any training data from the utopia because it's not real. Nonetheless, there are cases or kinds of transformations for which we can partially undo. And that's a very exciting and very new area of work. So that's it. Any questions?
This talk was pretty abstract, right? It's an abstraction of perhaps ways of thinking that can help us with the specifics. So I'm wondering if the way you think in this work and the first talk, would you comment on how some of this could help in that scenario?
Yes. So I think that the multi-accuracy, multi-calibration work could be useful. It can't change the distribution. It can't change the data. The data are the data, and that's a whole other topic, which is how do you get better data and more informative data and better distributed data. But you mentioned maybe training separately on different groups, but then you have to decide sometimes like which group is somebody in. Here, and maybe you even need to make it unique, which is the classifier or the scoring function we're going to use. Here, you can be in multiple groups and we end up with a single scoring function, and yet within each group it's calibrated. So I think it might be helpful for the kinds of things, some of the kinds of things that are of concern to you. And I got, pretty excited listening to your talk as a result. There was another question. Yeah.
It was almost the same question. I was like, so I am a computer science major at Trinity College. So, but I do large language model and machine learning in healthcare. But then the problem is you mentioned like we are all things we care about is loss minimization, which is like to minimize the loss between like accuracy and, but like the data we are using is coming from already biased.
Right.
And when you train machines on the already biased, you're basically enforcing the bias, like machines like be more biased. And that's where like it was like kind of you touched base on it on like how can you like basically reduce that.
Right, so there are multiple sources of bias in the data. And some of it could be, for example, from biased labeling being applied in the historical data, right? But other sources of bias are distributional or just the conditions of people in different groups. But one thing that, one thing I didn't mention and I should have, is that suppose you have some artisanal method of prediction that you've worked on for years and it's great. You finally have collected the data you need and so on and so forth. You can apply all of these techniques as sort of post-processing. You start with an arbitrary predictor, and then you can, on top of that, modify the predictor to make it multi-calibrated. And you can provably lose you're going to gain in accuracy. You're not going to lose in accuracy. You're not going to lose accuracy. So it doesn't address just if the data you're starting from are garbage, there's nothing you can do. But you can improve on what you have managed to do so far.
Right. Our next speaker is Dr. Pasaniuc. He's from UCLA. Today we hear about polygenic risk scoring in personalized medicine, promises and challenges.
Thank you. Thank you so much for inviting me here. It's exciting to come back to the place where I trained and see old friends and see how everything kind of looks the same outside, pretty much. So today I'll be talking about polygenic risk scores, and I vaguely titled this as promises and challenges. And I promise you that I haven't really synced with the previous speakers, but my talk, you can view it as a more of an applied version of the talk that you just heard before. So I'm going to talk a lot about calibration, and I'm going to talk a lot about how genetics is a promising tool, but we need to calibrate. And you'll see it in my my slides today. So unlike the other speakers, I'll be bringing here the genetic vibe to it. So essentially, I figure out how to play this. Okay, so obviously in medicine, we're trying to move away from something that applies to everyone to, this general idea that we want to personalize or make things more precise, one patient at a time. And obviously, because I'll be talking, or I'm a geneticist by training, I'll be using genetics as a tool that we can use to personalize or tailor, risk prevention all the way to medication. So the general idea is that next time that you go to your clinician, either primary care or cancer care, your clinician will pull up your record based on your genome and will figure out whether, let's say, you might be at higher risk for certain diseases versus others. And as a very toy example here, let's say I might be at a higher risk for prostate cancer based on my genome. I might be a lower risk for heart disease. I might be higher risk for asthma, and all these common conditions. And the general idea is that genetics, which is at birth, so germline genetics, to be more precise, can be used to infer all these predictions, if you will, or can be used as a prediction tool. And then the clinician will have accessible to them, directly before you even set foot in the hospital, all these data that they can use to make better judgments about your care, essentially. So you might think that this is kind of like, science fiction or something that will come out in, we shouldn't care about it because it's so far in the future, it doesn't matter. Every time that I give this talk, it's less and less, or it's more and more closer to actually happening. So I'm telling you that this is already happening. It's you can actually go on Amazon and buy all these kits that will give you, these types of profiles. 23andMe just added a polygenic risk score for colorectal cancer just a couple of weeks ago. You can just literally go and buy it. And this goes all the way to, I have there on the left side of this slide, things that are ethically dubious, things like how do you use polygenic risk scores for pre-implantation embryo selection, which it gets closer to, discussions about eugenics, if you will, right? So these things are happening, and I put it there because as scientists, we need to think about the predictive powers and biases of all the methods that we have, because the companies will actually use it and sell it to the consumers. On the other side of the slide here, I'm pointing some big, large-scale consortia that probably some of you are already part of it, emerge, primed, or intervened from the European Union, that are hundreds of millions of dollars from our taxpayers, from NIH, funded by NIH, that are designed to essentially build these predictors and test how they would be implemented in the clinical sense. So before I get started, I just want to put something out there that we should all be on the lookout, and we should use it as kind of essentially a quick how to understand this polygenic story, the influence of genetics and genetics medicine. The first thing is that genetics is just one part of the story. So every time that you hear about genetic determinism, that's already kind of like pushing it too far. Any trait that we measure in humans that is common enough has genetics and has non-genetic factors. Cancer is probably one of the prime examples. So in absence of environmental or other non-genetic factors, we can think about any genomic predictor having an error bar or having a limited utility. There's never going to be a genetic predictor that will have 100% accuracy. So we need to worry about errors and biases in these predictors. The other probably biggest discovery in the past 20, 30 years from all the large-scale genome-wide association studies in humans is that everything that we measure in humans has a lot of genetic factors that drive it. So, breast cancer, prostate cancer, any type of condition or common disease in humans has hundreds, if not thousands, if not tens of thousands of tiny locations or locations in the genome that each of them have a tiny impact on that disorder. So this has been labeled as the polygenic architecture of common diseases in humans. And that tells us that any predictor that we can think about for predicting diseases in human or humans needs to aggregate this data across many of these predictors. And this really raises this idea of summing all these predictors into the simplest statistical model that you can use for prediction, which is a linear model. You're just summing all these effect sizes by using some weights, and that by itself will have improved prediction over just looking one gene at a time. Okay, so these are just like simple statements that hopefully we can all get on board. The biggest problem that we're seeing in genomics and beyond genomics, you've heard about this in AI and this beautiful talk from this morning. In genomics, we see this problem that if you take one of these genomic predictor tools, it has disproportionate performance as you move away from, a genetic ancestry of Europeans. So this is a famous figure from 6-7 years ago from folks here at MGH, Alicia Martin and colleagues, that looked at the prediction accuracy of a genomic predictor, and they labeled it as different groups of individuals: European, American, South Asian, East Asian, and so on and so forth. And I use quotation here because I'll get back to you in a couple of slides what it means to be European or American for this figure, right? Which is, you can probably imagine that it's not an easy thing to get in, right? But you can already see that a predictor that predicts a common disease has 4-fold less accuracy in individuals that self-report as African Americans versus Europeans. Massive problems, right? It's critical problems.
Why is there variability? What would be the points here? Different studies?
That's a fantastic question. So the variability here is across multiple diseases. So in this study, they looked at 20 or 30, maybe 100 diseases or so, and they tried to get a general sense of how this prediction goes across. So you have lipids, cancers, and so on and so forth. So that's where the variability is. But that's a fantastic question. There will be variability across individuals too. And I'll get back to it in a couple of slides. Any other questions so far? Okay, good. So promise I didn't create this slide while hearing the talk before, but what the reason why I'm trying to convince you today is that before we take any of these prediction tools and actually implement them in medicine, we want to calibrate, right? And this is, I think, exactly one of the messages that I get from the beautiful talk that preceded mine. So in this particular case, what do I mean by calibration? So here's predictions of, let's say, 5-year of the probability of getting, let's say, breast cancer, and that's on the x-axis. That's what this predictor will predict. On the y-axis is what we actually observe in a population of individuals, right? And you can see in the red population, these kind of tracks with x equals y line. So we're making errors, but overall, if we're saying that this particular person will have a risk of like 10% to get breast cancer, roughly we're in that ballpark. However, for the blue population there, we're saying we're making way more essentially, errors, or we're biased, we're miscalibrated. We're saying more of these folks in the blue population, which, as you can imagine, will be a non-European ancestry population. We're making more mistakes there that will lead to more, more problems when we provide care. So once you see those plots, one of the first, if you're a geneticist like myself, one of the first questions that you might ask is, why is that the case? Is it the case that the genetic effects that these polygenic risk scores are trying to tag, are they themselves changing across ancestries? Is a variant that causes disease or increases risk for disease in Europeans, is that the same variant going to be, causing or not having any effect, let's say, in African Americans or in other populations, right? And that speaks up to probably one of the most fundamental questions in human genetics for the past 100 years, which is whether the genes or the cause disease in the same way across different ancestral populations. And as you can imagine, this was studied at length over the past, decades, if hundreds of years. And the standard approach of studying this is to collect data in multiple populations, let's say Europeans versus Africans, or Europeans versus Asians, let's say, and then compare the genetic basis across these groups. But that type of study is inherently confounded, because like I just told you before, genetics is not the only factor that contributes to disease or common diseases. There's exposure, there's environment, even the way phenotypes or disease gets measured across these broad classes of ancestries differs. One of the case studies here is depression in Asians versus Europeans. And then the way that the depression gets measured is biased, or it's different, I should say, in these two populations, which leads to essentially false discovery as genetics will be different. So to try to tackle this question, we went back to individuals that happen to have genetic ancestries from multiple sources in their population, in their genome, sorry. So such individuals are traditionally labeled as mixed. So they have recent ancestors from multiple sources. And you can imagine here individuals that self-report as African Americans within the US, or individuals that self-report as Afro-Caribbeans within the UK and other places in Europe. And a feature of their genomes is that the segments in their genome can be traced back with ancestry to these different ancestral sources, which allows you to quantify the impact of a given genetic variant in the same individual or in the same population on different ancestral backgrounds, while accounting for all these sources of heterogeneity. And we, I'm not going to show you all the statistics, but you can throw this into some fancy variance components models, and then you get at the end of it, if you analyze lots and lots of data, and here we analyze data from all of us, which is the largest data set within the US, very diverse, UK Biobank, as well as other studies. And if you line up all these diseases one at a time, and you do this comparison of genetic effects within admixed individuals, you see nearly perfect correlation in their impact of a particular genetic variant on disease outcomes. So what this tells us is that biology is all the same. If a variant causes disease in one population or one ancestry, it will cause more or less with the same effect in other ancestry. What really changes across ancestries is the frequency or the number of carriers of these mutations. Some populations might have more carriers than other populations. That's why we might see differential genetic basis of diseases across different ancestries. So getting back to this plot that I showed you before, what we think is happening underlying this this potential discrepancy is that the amount of variance or frequency of these causal variants changes across ancestries, and that's why we see this differential or this decay in accuracy. But that opens up another can of worms. And the big can of worms gets back to this labeling of individuals. One of the things that we're seeing nowadays across large-scale cosmopolitan biobanks, and here I'm showing you two of them, one at Mount Sinai in New York City. So that's like 50,000 people within their medical system. There's another 40,000 at UCLA and our biobank called Atlas. If you take their genomes and you project them on principal components, which is a standard tool to reduce the dimensionality of the genetic data. So every dot there is one patient. And then on top of them, we're projecting individuals for which we know their ancestries. You start seeing that genetic diversity sits on a continuum of genetic ancestries. These so-called clusters of genetic ancestries are just artifacts of the fact that we didn't have enough sampling of the data when we actually, essentially infer them. And we see this across these biobanks, and this has been replicated throughout. And just because the next talk is going to talk about genetic ancestry versus self-reported race ethnicities, we can already see big discrepancies between self-reported race ethnicity concepts, which are a social construct with what individuals self-identify as, versus genetic ancestries as defined from in reference to how the genome is more similar from other data sets. Here on the left side of the slide, you see a Sankey plot, I think it's called, genetically inferred ancestry across these major broad classes of genetic ancestry versus self-identified race ethnicities. And you see how different they are, particularly for given populations, right? And you see that they're not the same, they're different concepts. So getting back to this what does it mean to be American on that plot? What really happens under the hood is that there's a continuum of genetic ancestries, as cartoonishly shown on this figure. There's a clustering method that imposes these clusters on this figure, and then from that we can conclude that individuals in these different populations might have lower performance on these polygenic risk scores. However, that has multiple problems. So one of the big problems is that it throws away a lot of people from the data that happen to have complex genetic ancestries. And I'm sure that happens in Boston as well, but in LA, we see roughly 1 in 10 people are not really falling in this broad classes of genetic ancestries. I'm showing you some folks there as an examples that all have this feature that they have recent ancestors, a grandparent, a mother, father, that happen to be from different genetic ancestry clusters, and therefore all these individuals will be thrown away from all genomic studies, and eventually will be thrown away from all precision medicine, if you will, which is a terrible idea. The other part is that if you start, because genetic ancestry sits on a continuum, if you start zooming in on some ancestry groups, you start seeing more structure. So this speaks to the fact that clustering is not a perfect approach, and it has some parameters that we often ignore. So in this particular case, in our data, if you zoom in on the Asian genetic ancestry cluster, you start seeing all sorts of other types of individuals that happen to self-report as different countries or different ancestries within Asia. So all those would be ignored in all those plots before. So to avoid that, last year or a couple of years ago, we proposed to drop the clusters all together and start thinking about genetic ancestry as a continuum. Start thinking about as a distance metric, which resonates to the talk before. So essentially a number that tells you how similar one genome is with respect to a training data or a data that was used to train this prediction model. So in population genetics, there's a simple way to do that, and has very similar meaning to fixation index and so on and so forth. So there's a lot of theory behind it.
Sorry, so you've been using clustering as a self-reported, because for clustering you need distances if you're going to do it mathematically. So the clusters you've been talking about, those are not derived from a distance.
They are derived from distance. So there's distance there, and then so there's no self-report there. They're clustered, there's a distance behind it, and there's a clustering that's imposed on this. Yes.
You're saying, now you're gonna say keep.
I'm saying keep the distance and don't do the clustering. So, and the keeping the distance is a little bit different, but yes, I'm saying let's not do the clustering altogether. Just keep the distance, and with some very simple theory, you can show that the distance is sufficient to explain. Let's see if I have the next slide. So essentially, you have a distance. It just happens to be a very simple Euclidean transformation on the pre-C space. Yes, go ahead.
Is there a danger centering European as the start of the?
Yes. There's a huge problem if you do that. Here, I'm just showing you it as an example, but you can center it on whatever you want. And typically, the theory says to center it on the data that you use for training. So if you trained these predictors in, let's say, Africans, you should center it on that, on with respect to Africans. So this distance doesn't really have a biological meaning outside of just saying that this is the expected decay in the performance of a predictor if you had trained the model on that training data. So here I'm just showing you in Europeans because genomics has a European bias. That's why I'm showing you it on European, but you're absolutely right. Any other questions? So as I was just saying, if you take this distance and you go back to this biobank that we have at UCLA, every dot there is one individual, and there's a way to estimate under some assumptions the individual level accuracy, right? And that's what's on the y-axis scale. And then you can start seeing how this distance describes really well the decay in performance. So it's not a matter of like these clusters of populations, but it's an individual level effect. It's how much your genome is similar to the training data, more so than the cluster which your genome was allocated. And obviously, if you recolor things, you start seeing that all these individuals that were left unclassified are sitting there, and you start seeing this great overlap between the genetically inferred ancestry clusters. And this is not a feature, so we did a lot of work. This is not a feature of certain populations versus other. This happens throughout. As it turns out, not all Europeans are the same. So there's structure in Europeans as well, and we see this decay and so on and so forth. And you see this tight correlation between distance and accuracy in all the ancestries. But overall, this tells us that there's a bigger problem that's happening here. We often train these predictors on some training data and genetics, and typically we try to make the genetics as homogeneous as possible because we try to avoid false positives. That's one of the reasons why people have focused tremendously on European-centric genomic data so far, because we're trying to avoid as much as possible false positives. And then when we go about in clinical practice or in precision medicine, often the individuals have different genetic ancestries than the data that was used in training. So genetic acid is just one aspect of it. There's all other contexts, which I'm not talking about today, but I'm happy to talk about it. There's income, social determinants of health. All those things are different, and they all impact the prediction accuracy. Again, saying that context matters, and genetic ancestry is just one of the many contexts that matters. So one thing that we started thinking about it is how can we try to fix these predictors? And what if I had told you that if we had a data that matches really well the patient population that we currently have, that we can calibrate all of our models, we make sure that they work fine, and then next time that a patient comes through to the door, if we're making the assumption that the patient that comes through the doors has the similar characteristics as the calibration data, then we can guarantee that the methods are working as they should. And before you start thinking about this calibration data as kind of like pie in the sky, I can guide you that these types of data are already being generated. Most medical systems within the US and beyond are creating large-scale biobanks of their patients with a purposely guided goal to calibrate these predictors. Here I'm showing you just a couple of them from global biobanking meta initiatives. And I even go one step further. I think medical systems that do not have a biobank with genetic data from their patients linked with their context will be at a huge disservice in the long run, because you won't be able to apply these methods before you test them in your patient data. So how does it work? I'll kind of briefly, because I'm running out of time. There are methods that you can do the calibration. And here I'm showing you an approach that we did for lipids, so predicting lipid levels. And lipid levels, the sex is as a confounder. So you do a much better job predicting in women than in men, as it turns out. And the way we propose to do it is to take this biobanking data. We have the measured phenotype. We have the predicted phenotype. And then based on the discrepancy between them, we can fit a model that will readjust our predictions. And the model, just because we're in a data science place, this is the only math that I'll show you. It's quite simple. It impacts, there's a mean effect there from this context. And there's also a variance effect, because it turns out that variance, there's a lot of heteroscedasticity in the data. So you can fit them all jointly, and it's a kind of a simple problem. It's a well-powered problem, because we have these biobanks are pretty large.
CI or the genotype?
So in this case, CIs are not the genotype. CIs are the context, are genetic ancestries, age, sex, social determinants of health, any type of things that kind of like will impact the prediction, bias or error. And we're saying that we can readjust the prediction as a function of these contexts. And how do we do the readjustment? We fit it on the calibration data. So I'll stop here by hopefully kind of like a pinging of interest that causal effects, to the best of our knowledge, are very similar across genetic ancestries. Frequency, or the proportion of individuals that carry these mutations, are really the main drivers of this discrepancy in the effect. Hopefully we can start thinking about genetic ancestry continuum and less about clusterings of individuals based on genetic ancestries. And I'll leave you with the fact that I think biobanks are critical for any type of precision medicine that we can push for. So I'll stop here, thanking primarily the UCLA Health patients that contributed to this data that I showed you, a couple of them, as well as the students in my group that have done quite a lot of the work. Thank you. And if you have any questions, happy to answer. Yeah, go ahead.
Thinking to ask for the calibration methods, like with the data from different medical centers, do they use the same principled ways to do the calibration or not?
That's a fantastic question. I think it's very early stages. So we are proposing to have a similar model, but then the coefficients or the effect sizes might be different. Also, the effect size or different contexts on this prediction, because we think in general, there's like 30, 40 variables that matter there: genetic ancestry, social determinants of health, age, sex, smoking, and so on and so forth. But we're still very early stages. So I'm not aware of other medical systems that are doing this, actually. So we're definitely proposing, and we're a big fan of it.
Do any of the commercial companies do calibration?
That's a fantastic question, which I'm not aware of. Either they don't do calibration, or they keep their data proprietary inside. So they don't tell you what the calibration, if they do it. And if one of the things that we're advocating for is to open up that calibration profile. So essentially tell not just the measure of risk that comes from one of these predictors, but also what the data was used to calibrate and how all those things fit into the relative risk models. But to answer your question, I'm not aware. I don't think so. I could be wrong.
No, I think someone asked the question. We can talk later.
Okay.
So if I understand you correctly, you think that there's a true underlying model that is the same for all of you. And it says genotype times some coefficient, and that adds up and gives you your risk. So then is the problem then that when we train, we miss some of those dips that matter and don't even include it in the prediction? That's
Yes.
it. So it's just a matter. So we could go back and retrain again with a more representative data set, then wouldn't that give us Gets pretty close to the right model instead of calibrating after the fact.
It will give, yeah, but I argue that, yes, that's what I'm saying. There's kind of subtleties there. One is that some variants will be population specific, so you won't see them unless you actually look in that particular population. So that's I leave that on the side. But yes, that's what I'm saying. But I'm also saying that we're a long way till we would actually have that type of data.
I got you.
I even right now, although this the Eurocentric bias in genomics has been popularized for 5-6 years now, and there's literally hundreds of millions of dollars that have been put towards diversifying genomics. It remains the case that 90-something% of all the individuals in genomics are of European ancestors. And moreover, speaking as an Eastern European, when we say European ancestries, we're literally just saying Northern European ancestry. There's no, German, there's no Eastern European, there's no very little Italians or whatever in all these studies. So I argue that it's going to take a long time till we have, very, very nicely representative genomic data. But yeah, I think the model for disease, it's simple, right?
Next speaker is Dr. Guerra from University of Pennsylvania. Today, she's going to talk about use and misuse of race and ethnicity in biomedical research.
And while the slides are coming, I just want to say that I was in Orlando for the National Comprehensive Cancer Network, where I was chased down by a tornado and then came home to Philadelphia, where we had an earthquake. So I can't vouch for your safety in Boston, given that all the disasters that are following me. But thank you so much for being.
Yes.
What's that?
When you get here.
But I am so honored at this invitation to join you, and I really am thankful to the committee, Erica and Sandra and Chris, who's a dear friend and not here today, Giovanni, and thank you, Rafael, for this honor. But I most of all want to thank Dr. Zelen and his lovely family, who I just had the pleasure of meeting today in the video call. And we're joined today by his family here today, also generously sharing their valuable time, as you are, to join us today for this wonderful symposium that really does honor his legacy. Before I begin, I just want to say that I read about Dr. Zelen, and the more I read about him, the more I really began to admire him, and can't help but think of the many things that we have in common. So he and I grew up in New York City, and he and I were in upstate New York, and he in Buffalo, and for about a decade, and I myself in Rochester, where we both probably saw the most snow in our lives that we probably ever have seen. And he too had a passion for cancer, as do so many of you. But the one thing that really caught my eye was that he also strongly believed in science that was free of error and free of bias. And so with that in the background, I really am excited to speak with you today about some of those concepts. So first, some disclosures. When I asked the committee about what I should present today, they came back and said, actually, it was about this report that I'm now involved in by the National Academies of Science, Engineering, and Medicine. This is the first committee that will issue recommendations on the use of race and ethnicity in biomedical research. Shockingly, there are no recommendations on this topic. And that may explain why this topic the topic of race has been misused in research. And so with that, the objectives that I had in mind today were to talk about race as both a myth and the reality, and then to examine the use and misuse of race in biomedical research, and then perhaps spend the second half of my talk taking a look at recommendations, with the disclaimer that these are just my perspectives and opinions and not those of the NASEM committee, which will issue its report in October. So first, race as a myth. So for 5 decades of research has shown that race as a biologic concept has been invalidated Multiple disciplines have produced this research, biologists, geneticists, social scientists, and they all reject that race is a biologic concept. In 1999, the Human Genome Project also emphasized that race was not biologic and that there was no basis in the genetic code. There was no race that actually had a discrete package of genetic characteristics, and only about 6% of the DNA differences in humans were differences due to racial differences. And that leaves us with the truth, which is that race is a social political construct. And historically, as everyone here knows, race was used to categorize people in groups based on how they looked and different characteristics. Yet that hasn't stopped researchers from using race to explain biologic differences in humans. And so the problems with using that approach is I'm going to summarize in 6 points. These are the first 3, that race has been shown to be a poor proxy for ancestry, and we already just heard that the definition of race has and continues to change over time, and that the meaning of race is actually context specific across cultures and geographies. So looking at these points a little bit more closely, as you can see on the top left, these 4 individuals would classify themselves as white, but you can see their varying ancestries there. And on the top right is a very famous study now performed in Cleveland that looked at self-reported race and the admixture ancestry. And across, you can see the percentage of people with genetic African ancestry. And then in the columns, you can see the self-report. And in individuals with 0 genetic African ancestry, you can see there were still people who reported themselves as Black. And as you go along, there's a continuum here of different variations of report. And then the media is just full of examples of people who took a genetic test and realized, oh my gosh, I'm not that ancestry at all. This gentleman, Mr. Joseph, was a principal who took a genomics test only to find out that he had been telling everybody he was Black his whole life, and only to find out that he had no African ancestry. And the same thing with this woman on the right. She thought she was Hispanic, but learned that she actually had all of these ancestries mixed. A study recently showed that when people take these genetic tests, they are much more likely to classify themselves as multiracial than before they took these tests. The second point is that race is fluid. It has not been a concept that has been defined the same way across time. And you can see this is just from the US Census, how the US Census defined race starting back in the 1700s. There were only these 3 races. And then it started to shift to colored people, which is the word they use initially, and then mulatto. And then, as we all know, in the middle of the 20th century, there were rules put upon what actually defined white and non-white races. And then we've all heard about the one-drop rule. And fast forward into today, just last week, you may have heard the announcement from the OMB has added a new racial category. So disaggregating the Middle Eastern and North African group from the white category, which is how they've always been classified. And then the definition of race is context dependent. This is Neymar da Silva Santos, who's a Brazilian soccer player, very famous soccer player. And he caught the New York Times attention one day when he was being interviewed after a game. And he was asked about racism in the sport. And he said, "It's not like I'm Black." And most people in the US were shocked because they would look at him and most people would say he is Black. And he's someone who represented the Brazilian American Cultural Institute in Washington, D.C., actually put it in focus in the article. He said, in the US, if you are not white, then you are Black. However, in Brazil, if you are not quite Black, then you are white. So it's very context specific, which makes race very problematic. The last 3 points about how problematic the use of race is in research is that we tend to classify race into these discrete little buckets. But if you really look at race, it's more of a continuous variable, as this picture identifies. And so how can you put these people into discrete buckets? Based on what? And finally, that race is a proxy for other modes of classifying people. Maybe the race represents racism, as we heard earlier. And finally, oftentimes these racial terms are misadjudicated and misused. For example, it was up until the 1960s that it was the census collector who identified a person's race just by looking at them. For example, in our electronic medical record, EPIC, people who were checking in the patient were filling in the race. So there's a lot of problems with using race as a variable. And we've talked about race, but ethnicity is even more complicated because it is a social construct. There's less controversy about that. And it represents many things: cultural expressions, national origin, religion, customs, ancestry, name analysis, language, etc. And these are some of these examples of ethnicities. And like race, the meaning can change over time and place as well. So let's look a little bit about how researchers have used and misused race. So even though we know race is not a biologic construct, the community has still used race to explain differences in disease, prevalence, and outcomes. And researchers have usually collected and used and reported race without usually explaining what race stands for. So if it's not a biologic construct, then what was it measuring? And what we find when we look at this research is oftentimes researchers probably used it as a proxy to measure something else. And that something else can be any of these things. It could be class, it could be culture, it could be skin color, it could be diet. But there's often no explanation in the scientific papers as to what race represents. So what typically happens is something along this line in epidemiologic research, which is what I've been focused on. A researcher will conduct an analysis, see that there's an association between race and an outcome, perhaps a worse outcome, and then someone else comes along and develops a predictive tool that includes race in that predictive tool. This is now called race correction. And then that tool is then applied clinically. And resources are sometimes withheld from individuals based on the results of that predictive tool, which then only exacerbates disparities, health disparities, and actually cements structural racism in the healthcare system and the science that we perform. And so here are some examples of these race-corrected clinical predictive algorithms. There are so many, and these are just a few, and I'm going to talk about just two of these. As an example, the American Heart Association developed a Get With the Guidelines heart failure risk score, and you can see on the right what the calculator is based on. And what it does is it tries to predict in-hospital all-cause mortality in patients who come in with heart failure. And when the race is ticked off as Black, then the calculator gives a lower mortality for those individuals. And it's not clear why. The authors don't explain why that is. And so what happens in real clinical delivery and healthcare systems is that when a patient who is Black and this formula is used, they assume that the patient's at lower risk, often then making important decisions about perhaps withholding certain resources. Maybe the patient doesn't need to go to the ICU, for example, because their risk is lower, when in fact that may not be true. Another example here is something called a sequential organ failure assessment, or SOFA score. And this is very similar. It's for critically ill patients that come into ICUs, and it tries to determine their outcome. And it's used to allocate resources. And from that grid that you can see here, what you'll notice is that there's a lot of organ failure variables here, which already disadvantages some minority populations because they tend to have a greater burden of comorbidities. And it turned out that this actually did show that there was a study done of the SOFA scores that showed that in over 113,000 patients in 27 hospitals, 81.6% of Black patients were assigned a lower priority score, and 9.4 were actually erroneously excluded from the highest prioritization. So these algorithms can be discriminatory and reinforce racism. So what is the impact of this? As I mentioned, real resources can be withheld when people use these, and it also reinforces these erroneous assumptions that race explains biologic differences. And if we were to offer a rationale in a paper as researchers, sometimes when you trace that rationale, it leads to suspect and perhaps not very rigorous science. Finally, if you do all of that and don't have actually rigorous science, you can cement these racist social structures. So, to put it in the words of the individual from the Doris Duke Foundation who commissioned this report, along with Burroughs Wellcome Foundation, in their words, they wanted us to think about this problem as a research community because research using race has real consequences and has resulted in a legacy of race-corrected equations and clinical algorithms that have caused real harm. So how do we move forward? So as I mentioned, there are currently no clear guidelines on the use of race and ethnicity in research. And there are opportunities where it actually is appropriate to use race, but those have to do more with determining whether patient populations access and engage with research, and if they are represented in research, so that that research can be more generalizable across populations. It also increases the efficiency of research if you're recruiting for multiple populations rather than just one. But it's not appropriate to use race and ethnicity to explain differences in biologic outcomes when there could be other explanatory variables. And so what are those explanatory variables that could be perhaps underlying that label of race? And I've listed a few here. And when race is being used, for example, as a proxy for skin color, I've listed also examples of potentially more accurate measures that can be used. So the first step would be to think about, what does race represent? And does it represent another variable that perhaps race is a proxy for? And what is that variable? And if you can think of those variables, identifying better measures for directly assessing the impact of those variables. But that's in an ideal world. We know that sometimes that's not possible. So I'll come back to that point. You notice that I had race here at the very end, and I wanted to make a quick point about that because racism can be at the interpersonal level or on the structural level, as we've heard earlier. And so if you think that race is representative of racism, then you have to think about, is it representing the structural barriers that individuals face? Or is it the experience of being Black in America, for example? Is it causing a higher allostatic load? Is it causing toxic stress? Or is it both? And sometimes there is conflation between race and racism, and there's difficulty teasing that out. So how do we move forward? We mentioned disaggregation is sometimes not possible because what tends to happen in research is people will find a data set and then they'll come to us, the mentors, and say, I want to study XYZ in this data set. And so these legacy data sets don't sometimes allow us to disaggregate race from whatever that race is standing in for. And so in those cases, it might be very difficult to do that. And in those cases, we shouldn't ignore race, but instead think about what it might mean in our conceptual framework. And as we discuss the results, do so in that contextual framework. In addition, if race does appear to correlate with outcomes, and as I mentioned, we have to ask what it represents. But the answer could be really difficult here because the real answer is, how does race affect the outcome? And it's difficult to tease out sometimes the race and the health effects that are also enmeshed in social and behavioral and environmental and biologic pathways that closely track race. And so some people have suggested perhaps in those situations when you can't, where you cannot untangle it, it would be insufficient to translate race into a data signal because you can't untangle it. Other people have suggested that using these developed tools, if you don't untangle it, again, can lead to this cementing of the structural racism. So here's a summary of some of the ways that race can be used. As I mentioned, it's not appropriate to use it as an explanatory variable for biologic outcomes when there are potentially other explanatory variables in the social or environment or behaviors. It is appropriate to measure, to use race to measure access to research and engagement with research. And it might possibly be appropriate if it's in a conceptual model, disaggregated from other possible covariates that can be measured more directly. And so whether to use race or ethnicity is, in many cases, is appropriate. It requires further research into the complex interactions between ancestry, race, racism, socioeconomic status, health behaviors, and environment. And this is, again, very tough to do, but that's where I think the science is asking us to do at the moment. And some people have suggested that if perhaps these things are all entangled, one way to look at them is to look at the interactions between some of these variables. And so that leaves us with much work to do because that burden falls on all of us to bring the rigor to the research that we do around race. So I think with that, I'll just end by inviting you to see the upcoming report when it's published in October. Thank you very much.
I'm a biostatistician and I work with a lot of PIs that we're running a table one. We're going to put race ethnicity. We're going to put all these things. Do you have a helpful, maybe a conversation starter of how to switch that narrative and ask them to engage in maybe a more broad conversation about what they're actually getting at?
Thank you. How do you do that? I love that. And here's how. There's so many people that understand the complexities of this. Invite someone to your team that understands the complexity of this. You've heard from so many speakers today that understand some of those complexities. And so diversifying our teams is one important way that we could begin to untease out race from all of these other complex relationships. But I love the question, and I think that would be a really great way to do it. I also will put my money where my mouth is. So if you ever have a variable that called race and that you're seeing an association, I'm happy to help you look at that.
You made an argument to not use race when we have other variables like it's all we need for relevant studies, outcome studies. But you're saying we should use race to let people into studies and that, but it seems a little bit of a contradiction there. Can't we? Doesn't the same argument apply to the including people part of that argument? Like you could also use the other variables to let people in.
Oh, yes, I didn't mean exclusively just use race. Of course, yes, we want your population to mirror the population that the research results will apply to. And I think if you have sufficient numbers of racial diverse populations, it actually helps to understand, what is race representing? Because if you don't see it in people who don't have that racial variable, so I think it also informs the hypotheses that might arise from the research. I think that was.
Yeah, there is one that I was doing, and I saw like the increase on recent publication of papers of land, like for the land images, that increases the number of publications that were done on machine learning for land prediction. So my question is the correlation of available data and the amount of research that's done on that data, that like the availability to those research. So that comes to like the availability of more diverse data. What's the effort which is maybe being put into getting more of that data to be able to get even scientists or to we are pointing out the problem they're having, but it's the data they have. Now, how can we also increase that together?
You hit on one of the recommendations that might come out of this report, which is the diversity of the data sets that are available. This report will inform funders. And so we think that perhaps the funders can help control the creation of these cohorts that build those data sets, and the diversity of those cohorts perhaps can be addressed by increasing the diversity. We can address some of these questions.
Yeah, another question that, so most of the funds US is so diverse. I'm from Rwanda. So, but the question is, how is, we are familiar like how like global health or like public health, one problem somewhere impacts the whole world. Is the US or like kind of in the what you're doing, and most of the grants when they're given, they're kind of funding the country itself. So would they consider funding the data collection globally to increase the diversity, because they use diversity to get those data for their population?
I'm not sure if I can answer what the funders might do to fund more global representation, but we'll see. You know, we certainly agree with your fundamental point, which is these data sets should be more diverse. Thank you.
Please join me thanking all our 6 speakers today. It was a wide range of topics that I learned a lot. Something new for me, theory of algorithm fairness, the complexity of using defining genetic ancestry based on clusters, the definition of race and ethnicity that we use all the time, how complex this can be, and then timely discussion about role of AI in early detection and diagnosis. And of course, structural racism, how complex it is, and we can tease down to details so that we can actually use some of it in the modeling work. So these are all the components of health disparity research. So I thank all the speakers again. I thank our department chair, Rafa, and organizing committee, and especially Erica, working with all the speakers, making this event happen. And also thank you, Susie, being here helping us. And also Matt for being here as Marvin family. Marvin will be very proud of you. Thank you all for coming.